Structural nasal tip support. Anderson's tripod concept. The lower third of the nose has a tripod-like support structure that is made up of the conjoined medial crura and lateral crural complex based bilaterally on the piriform aperture, has frequently been cited to support methods for altering the lower lateral cartilages. The publications by Anderson and Janik and Wright on major and minor tip supporting mechanisms have also become a widely accepted means of explaining tip dynamics. More recently, Adamson et al. Described an expanded version of the tripod concept. Their M-arch model describes the conjoined medial and lateral crura as a continuous elastic spring, the curvature of which creates intrinsic tension in the structure. The easiest way to envision the nasal tip is to compare it to a three-legged chair. The legs of the chair give support to the tip, while the seat of the chair is the tip. To change the height of the tip, one must change the length of the legs. To change the shape of the tip, one must change the shape of the seat. In addition to the nasal ligaments, another source of tip support has been postulated to be the relationship between the anterior nasal septum and the alar domes. Beidick et al. Stated that in the normal nasal anatomy, an anterior septal angle of sufficient height keeps the feet of the medial crura off the anterior nasal spine. The medial crura do not bear a significant load. Constantine considers the anterior septal angle-to-tip relationship to be the cardinal point in planning and performing tip surgery. However, what is the actual anatomic relationship between the ASA of the dorsal septum and the alar cartilage? The consensus is that the ASA represents the junction between the dorsal and caudal septa. The posterior septal angle, PSA, is the junction between the caudal septal cartilage and the anterior nasal spine. Anatomic dissection proved that the domes are caudal to the ASA, average, 5.7 mm, range, 2.2 to 9.6 mm, while projecting above the ASA, average, 5.5 mm, range, 2.9 to 9.5 mm. This anatomic finding confirms the observation in 1985 by Lassard and Daniel, who stated that, in more than 80% of dissections, the alar domes projected far above the septal angle, 8.0 mm, thus discounting the concept of the septum providing direct support to the nasal tip. Interestingly, Bird et al. Recommended that the tip projection above the septum should be 6 mm in thin-skin patients and 10 mm in thick-skin patients, for an average of 8 mm. Thus, anatomically and surgically, the domes should project above the anterior septal angle. The lateral crural complex is supported by three structures: suspensory ligaments of the tip, fibrous connections to the upper lateral cartilage, and abutment with the piriform aperture. Major tip support structures. Fibrous connection of lateral crura to the upper lateral cartilages. Abutment and attachment of the lateral crural complex to the piriform aperture. Fibrous connection of the medial crura to the caudal septum and anterior nasal spine. Suspensory ligament of the nasal tip. Minor tip support structures. Fibrous attachments of the lower lateral cartilages to the dorsal septum. Lower lateral cartilage attachments to the skin. Membranous septum. The 6 key anatomic elements to tip projection. Supporting ligament between the anterior septal angle and the overlying dermis. Length and strength of the lower lateral cartilages. Suspensory ligament bridging the anterior septal angle. Fibrous connection between the upper and lower lateral cartilages, and septum. Abutment of the cartilages with the piriform aperture. Anterior septal angle. Nasal bones. The bony vault refers to the bony framework of the nose, containing the paired nasal bones and the frontal processes of the maxilla. The bony vault can be divided vertically into a cephalic and caudal portion. The cephalic portion is above the medial canthal ligament. This area is the radix of the nose. The bony vault has a different thickness in different areas, and the thickest part is in the cephalic radix area. Transillumination reveals the thick and thin parts of the vault. The pattern influences the location of lateral osteotomies. The lateral bony wall denotes the contribution of both the frontal process of the maxilla and the nasal bones. Note that bony hump removal is confined to the nasal bones, and all lateral osteotomies pass within the frontal process of the maxilla. The nasal bones are fused in the midline and can be raised like a car hood from the underlying cartilaginous vault. For too long, rhinoplasty surgeons were obsessed with removing a large hump using chisels or osteotomes to remove an en-bloc osteocartilaginous hump. Palhazzi et al. 2015 demonstrated that the nasal bones form a thin bony cap over the underlying cartilaginous vault. The nasal hump results from the upward thrust of the underlying cartilaginous vault rather than an equal contribution from the nasal bones and cartilage. To conclude, there is no bony hump, only a bony cap that covers a cartilaginous hump. The surgical implications of the bony cap concept are: 1. The hump removal sequence should be bone first, then cartilage. 2. The bone should be removed as atraumatically as possible. 3. The underlying cartilaginous vault should be preserved. In other words, the shape of the dorsum is governed by the cartilaginous vault, not its bony coverage. Paranasal sinuses. The paranasal sinuses are paired and symmetrical, air-filled cavities situated around the nasal cavity. Paranasal sinuses are named after the bones that contain them. Frontal, the lower forehead. Maxillary, cheekbones. Ethmoid, beside the upper nose, and sphenoid, behind the nose. Paranasal sinuses function as air-warming cells and help to defend the airway against pathogens. Theories also list other functions such as reducing total skull weight and changing vocal tone, although these are not primary roles. Nasal septum. The nasal septum consists of 1. Septal cartilage. 2. Sphenoid tail of septal cartilage. 3. Perpendicular plate of ethmoid. 4. Vomer. 5. Palatine process of maxillary bone. It should be noted that the septal cartilage extends more than 10 mm under the nasal bone. In addition to the quadrangular cartilage, the septum is composed of 5 bones: premaxilla, crest of the maxillary bone, crest of the palatine bone, vomer, and perpendicular plate of the ethmoid. The vast majority of septal spurs consist of vomerine bone overlaid with the sphenoid extension of the cartilaginous septum. However, bony deviations of the perpendicular plate are quite common. Care must be taken in septorhinoplasty to avoid excess lateral traction on the perpendicular plate of the ethmoid bone, as this can lead to skull base fracture and resultant CSF leak. For this reason, the resection should be done downward, and currently the use of precise piezoelectric saws are preferred. Nasal septum arterial supply. The blood supply to the septum consists of the septal branch of the superior labial artery, branches of the anterior and posterior ethmoidal arteries, and the posterior septal branch of the sphenopalatine artery. Kieselbach's plexus, Little's area, is a vascular anastomosis between the anterior ethmoid artery, superior labial artery, greater palatine artery, and the terminal branch of the posterior septal branch of the sphenopalatine artery. This vascular plexus is located in the anterior nasal septum and is the most common site of epistaxis. Nasal septum nerve supply. General sensation in the nasal cavity is relayed through branches of the ophthalmic and maxillary nerves. These include the anterior ethmoidal, infraorbital, and posterior superior alveolar nerves. Further innervation is provided indirectly through the pterygopalatine ganglion by the posterior superior nasal, greater palatine, and nasopalatine nerves. Nasal blood supply. Nasal blood supply is provided by a transfacial polygonal arterial anastomotic system that connects the internal and external carotid systems. The vessels which form this system: A. Right facial artery, B. Subnasal artery, C. Marginal artery, D. Lateral artery, E. Radix artery, F. Angular artery, G. Right dorsal artery, H. Left dorsal artery, 1. Nasal artery, L. Philtrum artery, and M. Superior labial artery. Both the internal and the external carotid arteries contribute to arterial supply of the nose. The angular artery arises from the facial artery and provides a rich blood supply for the melolabial region. A branch of the angular artery, the lateral nasal artery, supplies the lateral surface of the caudal nose. The dorsal nasal artery, a branch of the ophthalmic artery, travels along the side of the nose to anastomose with the lateral nasal artery. The dorsal nasal artery provides a rich axial blood supply to the dorsal nasal skin. The nostril sill and columellar base are supplied by branches of the superior labial artery. A branch of the superior labial artery, the columellar artery, ascends superficial to the medial crura and is transected by a transcolumellar incision during an external rhinoplasty approach. The sensory nerve supply of the nasal skin is by the ophthalmic and maxillary divisions of the fifth cranial nerve. Branches of the supratrochlear and infratrochlear nerve supply the skin covering the radix, the rhinion, and the cephalic portion of the nasal sidewalls. The external nasal branch of the anterior ethmoidal nerve supplies the skin over the caudal half of the nose. This nerve is usually transected by soft tissue elevation during rhinoplasty. The infraorbital nerve provides sensory branches to the skin of the lateral aspect of the nose.